Welcome to this audio recording. This is a clinical approach, a hypothetical case discussion with questions that test the key concepts for a particular disease presentation. In this episode, I'll discuss the case of a 45-year-old who lost consciousness following a road traffic accident. A 45-year-old male motorcyclist is brought to the emergency department after hitting the rear end of a car at highway speeds. He was wearing a helmet but was thrown from his motorcycle. He was found awake in the field by paramedics but then quickly became unconscious. His airway is patent, but his respiration is shallow and irregular. His blood pressure is 150/90, heart rate is 60 beats per minute, and respiratory rate is 20 breaths per minute. In response to sternal rub, he moans and withdraws his right upper and lower extremities. He does not move his left upper or lower extremity, and he does not open his eyes. His right pupil is 6 mm and non-reactive, while his left is 3 mm and reactive to light. There is no obvious head injury or laceration. There is no discharge from the nose or the ears. However, there is a right hemotympanum. The oropharynx is clear, and the rest of the physical exam is normal. Question 1. What is coup and contre-coup injury? Coup injury is a direct injury to the brain below the skull at the point of impact, while contre-coup injury is injury to the brain on the side opposite the site of impact as the brain is forced against the opposite skull. Coup injury is caused by a stationary head hit by a moving object, while contre-coup injury is caused by a stationary object hit by a moving head. Question 2. What is a concussion? A concussion is a term used for minimal head injury where there is a transient confusion or altered mental status following trauma. Symptoms may include headache, dizziness, confusion, personality changes, and irritability. There may also be problems with memory, balance, coordination, and concentration. A concussion may range from altered mental status to loss of consciousness. It is thought to be due to impairment of the reticular activating system caused by shear forces. Question 3. What is a lucid interval? A lucid interval is a period of regained consciousness between the first loss of consciousness, where there is disruption of the reticular activating system, and the second loss of consciousness, which is due to the expanding hematoma and mass effect. Lucid interval may last minutes to hours and is classically seen in epidural hematoma. Question 4. What are the signs and symptoms of raised intracranial pressure? Beginning with eye signs, there may be a fixed dilated pupil, papilledema, blurry visions, and abducens nerve palsy. There may also be headache, projectile vomiting, seizures, altered mental status, which may range from drowsiness to coma, and in infants there is bulging fontanelles. Question 5. What is Cushing's triad of raised intracranial pressure? Cushing's triad of raised intracranial pressure includes 1. Hypertension or a wide pulse pressure, 2. Tachypnea or irregular breathing, and 3. Bradycardia. Cushing's triad is also known as Cushing reflex. Blood pressure increases in the setting of raised intracranial pressure to maintain cerebral perfusion pressure. Increased pressure results in negative feedback at the carotid sinus, causing bradycardia. Raised intracranial pressure also impairs the respiratory centers in the medulla, causing irregular respiration. Question 6. What factors affect cerebral perfusion pressure? Cerebral perfusion pressure is affected by the arterial pressure and intracranial pressure. Question 7. What is the most powerful intracranial vasodilator? The most powerful intracranial vasodilator is carbon dioxide. Question 8. How is the Glasgow Coma Scale or GCS calculated? The GCS is calculated from 3 components: eye opening, best verbal response, and the best motor response. It is frequently assessed and reassessed to determine if the patient's traumatic brain injury is worsening. The score is graded as follows. A GCS of 13 to 15 is mild traumatic brain injury, a GCS of 9 to 13 is moderate traumatic brain injury, and a GCS of less than or equal to 8 is severe traumatic brain injury. Question 9. What is this patient's GCS? This patient has a GCS of 7. His best motor response is a 4, since he withdraws his right upper and lower limb from pain. His verbal response is 2, since he responds to sternal rub by moaning, and his eye opening is given a 1, since he does not open his eyes in response to sternal rub. A patient with a GCS of less than or equal to 8 is considered to be in a coma and their airway needs to be secured. Question 10. What non-head trauma factors can affect the GCS? Some non-head trauma factors that can affect the GCS include alcohol intoxication, drug intoxication, sedatives, severe hypoxia, shock, and severe hypothermia. Question 11. What is a blown pupil? A blown pupil refers to a fixed and dilated pupil resulting from the compression of the oculomotor nerve by the herniated uncus of the temporal lobe. This patient has a blown pupil on the right. The herniating uncus also compresses the ipsilateral cerebral peduncle, which results in injury to the ipsilateral corticospinal tract, leading to the contralateral hemiparesis. Question 12. What is lateralization and how can localizing signs be used to locate the site of intracranial bleed? Lateralization refers to the localization of neurological signs and symptoms to one side of the brain. The left and right hemispheres control certain functions of the body. In brain injury, specific regions of one hemisphere can be affected, resulting in characteristic signs and symptoms that manifest predominantly on one side of the body. Localizing signs are neurological signs and symptoms that can help determine the location of brain injury within the cerebral hemispheres. These signs include motor deficits such as hemiparesis and hemiplegia, asymmetric reflexes, sensory deficits such as numbness and tingling, visual field defects, and speech or language defects such as aphasia and dysphasia. In general, paralysis occurs contralateral to the lesion, while abnormal pupillary findings such as a blown pupil occurs ipsilateral to the lesion. Question 13. What is the localization of this patient's lesion? The lesion localizes to the right since this patient has left hemiparesis and a blown pupil on the right. Question 14. What would be the case if the blown pupil and posturing were seen on the same side? This is known as the Canohan-Waltman notch phenomenon. It is a false localizing sign whereby extensive midline shift caused by mass effect causes the contralateral cerebral peduncle to be displaced and compressed against the contralateral tentorial incisura or the Canohan notch, which results in paralysis ipsilateral to the lesion. Question 15. What is the implication of abnormal flexion of the upper extremity and extension of the lower extremity in response to painful stimulus? This is known as decorticate posturing. It is seen in lesions above the red nucleus. Disinhibition of the rubrospinal tract causes upper limb flexion. The vestibulospinal or reticulospinal tracts override the disrupted corticospinal tract, causing the lower bodies to be in extension. Question 16. What is the implication of abnormal extension of the upper and lower extremities in response to painful stimulus? This is known as decerebrate posturing. It's seen in lesions below the red nucleus. Both the rubrospinal and the corticospinal tracts are lost. The vestibulospinal or reticulospinal tracts override, causing everything to be in extension. It has a worse prognosis than decorticate posturing. Question 17. What are the signs and symptoms of a basilar skull fracture? The signs and symptoms of a basilar skull fracture include rhinorrhea, battle signs or retroauricular ecchymosis, raccoon eyes or bilateral periorbital ecchymosis, otorrhea, hemotympanum, and hearing loss. Question 18. What other signs should be looked out for in head injury? Other things to look out for include scalp lacerations, fractures, and primitive reflexes such as the Babinski reflex. Question 19. What is this patient's most likely diagnosis? This patient has severe traumatic brain injury as evidenced by a GCS of 7. He also most likely has a right-sided epidural hematoma. He displays the classic sequence for an epidural hematoma of consciousness, a brief lucid interval, followed by progression to coma. He also has signs of raised intracranial pressure and ankle herniation with a dilated non-responsive right pupil and left-sided hemiplegia. Question 20. What is the definition of a traumatic brain injury? A traumatic brain injury is a disruption of brain function with any of the following criteria met: either a period of loss of consciousness, loss of memory for events immediately before or after the accident, altered mental status at the time of the accident, or focal neurological deficits. Question 21. What are the differentials for traumatic brain injury? The differentials for traumatic brain injury include an epidural hematoma, a subdural hematoma, an intraparenchymal hematoma, diffuse axonal injury, or a subarachnoid hemorrhage. Question 22. How is the presentation of chronic subdural hematoma different from an acute subdural hematoma? An acute subdural hematoma usually presents less than 3 days of the inciting event with features of raised intracranial pressure, localizing signs, and a fixed dilated pupil. A chronic subdural hematoma, on the other hand, presents with progressive cognitive decline over weeks to months, ataxia, recurrent falls, personality change, aphasia, and memory loss, usually more than 21 days of the inciting event. Question 23. What are the goals in the management of head injury? The goals of management of head injury include maintaining mean arterial pressure at more than 90 millimeters of mercury, maintaining oxygen saturation at more than 95%, maintaining the carbon dioxide tension at 4.5 to 5 kilopascal in intubated patients, maintaining hemoglobin more than 7 grams per deciliter, maintaining normothermia, and maintaining normoglycemia. Question 24. What is the initial management of this patient? This patient needs to be resuscitated as per the ATLS guidelines. Of note is that they have a GCS of 7, which means that they require orotracheal intubation to protect the airway. Also ensure optimal oxygenation and ventilation, and this can be monitored through arterial blood gas analysis. His neurological exam should be documented before paralysis and intubation, preferably during the secondary survey, as this information will become useful once the patient is sedated or paralyzed. Intubation and paralysis can also facilitate the management of intracranial pressure. Once the patient is stable, obtain a non-contrast head CT and investigate for coagulopathy and correct if it's present. Other trauma imaging can be obtained depending on the mechanisms, and other laboratory investigations include a complete blood count, basic metabolic profile, group and cross-match, blood alcohol level, and a urine toxicology. Question 24. How can anticoagulation or coagulopathy be investigated and reversed in a patient with head injury who is taking anticoagulants? Anticoagulation due to warfarin can be monitored using the INR. It can be reversed using prothrombin complex concentrate or fresh frozen plasma. Anticoagulation due to direct-acting oral anticoagulants can be monitored using the thrombin time for dabigatran and anti-10A activity for rivaroxaban. It can be reversed using activated charcoal, idarucizumab for dabigatran, adexanet alpha for rivaroxaban, and apixaban. Anticoagulation due to heparin and low molecular weight heparins can be monitored using the partial thromboplastin time for heparin and anti-10A activity for low molecular weight heparin. It can be reversed using protamine sulfate, recombinant factor 7A, or prothrombin complex concentrate for fondaparinux. Antiplatelet activity can be monitored using thromboelastography or platelet function assay. It's usually reversed using platelet transfusion. Question 25. What are the indications for non-contrast head CT in traumatic brain injury? The indications for non-contrast head CT in traumatic brain injury include loss of consciousness at injury, neurological deficit, that's whether there was a GCS of anything less than 15, altered mental status or confusion, moderate to severe mechanism of injury, a suspected skull fracture and palpation, or a suspected base of skull fracture. Question 26. Describe the non-contrast head CT findings of epidural hematoma, subdural hematoma, subarachnoid hemorrhage, contusion, and diffuse axonal injury. The CT scan findings of an epidural hematoma is a hyperdense lens-shaped density adjacent to the skull. It does not cross suture lines and is usually associated with a skull fracture. For an acute subdural hematoma, there is a hyperdense crescent-shaped density adjacent to the brain parenchyma but not within the sulci. It crosses suture lines but not the falx. A chronic subdural hematoma presents as an isodense or hypodense crescent-shaped density adjacent to the brain parenchyma but not within the sulci. It crosses suture lines but not the falx. There may be mass effect which is out of proportion to clinical findings. A subarachnoid hemorrhage appears as a hyperdense material adjacent to brain parenchyma which traces along the gyra and the sulci. It's often in a coup or contra-coup pattern relative to the injury. Contusion appears as a hyperdense irregular lesion within the brain parenchyma, often in a coup or contra-coup pattern. Diffuse axonal injury appears as blurring of the gray and white matter junction. There may also be punctate hemorrhages and cerebral edema. Question 27. What methods can be used to control intracranial pressure? Methods used to control intracranial pressure include elevating the head of the bed to 30 to 45 degrees, which improves venous drainage from the head, reducing cerebral edema by using mannitol or hypertonic saline, sedation, analgesia, and close temperature regulation, which reduces the cerebral metabolic rate of oxygen. Anticonvulsants can be given if there are seizures. Temporary hyperventilation can reduce intracranial blood volume. Barbiturate coma, decompressive craniotomy, and external ventricular drains can be used to drain CSF. Question 28. How does hyperventilation help to manage raised intracranial pressure? Hyperventilation reduces the carbon dioxide tension, which causes cerebral vasoconstriction. This in turn reduces cerebral blood flow. Question 29. How does mannitol reduce intracranial pressure? Mannitol is an osmotic diuretic. It increases the tonicity of the extracellular space, which causes water to shift from the intracellular space, that's the brain parenchyma, to the extracellular space. It should not be used in patients with hypotension or hypovolemia due to its volume-depleting effects. It should also be avoided with intracranial aneurysm and arteriovenous malformations until the cranium is open because diuresis can expand the hematoma as normal brain tissue volume decreases. Question 30. What are the indications for intracranial pressure monitoring in traumatic brain injury? Indications for monitoring intracranial pressure include severe traumatic brain injury with an abnormal head CT, severe traumatic brain injury with a normal head CT but with any two of these, hypotension, posturing, or age more than 40, or in patients with suspicion of raised intracranial pressure when neurological exam cannot be appropriately assessed due to sedation or anesthesia. The normal intracranial pressure is 5 to 15 millimeters of mercury. Treatment of raised intracranial pressure is indicated for pressure more than 20 millimeters of mercury in adults with a lower threshold for children. Question 31. What is the preferred method for monitoring intracranial pressure? An external ventricular drain is the gold standard for monitoring intracranial pressure. Other methods include a subarachnoid probe, an intraparenchymal probe, transcranial Doppler, lumbar CSF pressure, and tympanic membrane displacement. Clinical signs can also be used to identify and monitor raised intracranial pressure, and this include headache, nausea and projectile vomiting, focal weakness, asymmetric pupils, Cushing's reflex, confusion, and loss of consciousness. Question 32. Is there a role for corticosteroids in the management of traumatic brain injury? There is no role of corticosteroids in the management of traumatic brain injury. This is because corticosteroids are used to treat cerebral edema caused by inflammatory processes and tumors. The mechanism of cerebral edema in trauma and inflammation are fundamentally different. In inflammation and tumors, there is cytotoxic edema, and this responds to corticosteroids, while in trauma, there is vasogenic edema, which is not responsive to corticosteroids. Question 33. What are the indications for a craniotomy in epidural hematoma and subdural hematoma? The indications for a craniotomy include midline shift of more than 10 mm, a hematoma with a thickness of more than 5 mm, intracranial pressure more than 20 mm of mercury, and a chronic subdural hematoma. Question 34. What is the indication for a craniectomy in epidural hematoma and subdural hematoma? The indication for craniectomy is raised intracranial pressure that cannot be managed conservatively. Question 35. When is a repeat head CT indicated for the conservative management of an epidural hematoma and a subdural hematoma? When an epidural or subdural hematoma is being managed conservatively, a repeat head CT can be ordered if there are new neurological signs, continued vomiting, worsening headache, loss of greater than or equal to 2 points on GCS, and any other signs of raised intracranial pressure. Question 36. What factors are associated with poor prognosis in head injury? Factors that are associated with poor prognosis in head injury include hypotension, hypoxemia, hypercarbia, raised ICP of more than 20 mm of mercury despite hyperventilation, advanced age, and a midline shift. Question 37. What is brain death? Brain death is irreversible cessation of entire brain function, including the brainstem. Question 38. What is required to perform an exam for brain death? In order to perform an exam for brain death, there must be a GCS of 3, euthermia, oxygen tension of 90 mm of mercury, systolic blood pressure of more than 100 mm of mercury, and the patient should not be sedated or paralyzed. A serum urine or toxicology screen is often required. Question 39. What is the criteria for declaring a patient brain dead? A patient can be declared brain dead if there are absence of brainstem reflexes, if there is no response to deep central pain, and when 2 physicians agree that the patient is brain dead. That's it for today. If this was helpful, you can find illustrations, questions, and more on this topic at hyperexcision.com. See you next time.